The main presentations in ovarian cancer at ESMO this year were on 3 frontline trials of PARP inhibitors for the treatment of ovarian cancer. This set of studies that was performed took the use of PARP inhibitors from patients with BRCA mutations into a much wider group of patients, as all 3 trials, one with Veliparib, the other with Niraparib, and the other with Olaparib, all showed a benefit of PARP inhibitor after chemotherapy and surgery for treatment of patients with ovarian cancer. It extended the progression-free survival and importantly looked at patients who did not have a BRCA mutation. Now all these trials looked at the tumor for presence of homologous recombination deficiency, because it's in those patients that we believe there is a greater effect of PARP inhibitors. And all 3 trials showed very similar results, namely a better outcome in patients with homologous recombination deficiency compared to those who were proficient in the repair of double-strand DNA breaks. There were also differences between the 3 trials which make interpretation and certainly comparison between the trials quite difficult. The PAOLA-1 study included Bevacizumab, and it was hoped that the addition of Bevacizumab to Olaparib, which was the PARP inhibitor used in that study, might actually lead to a synergistic effect. Unfortunately, that was not seen. There was no evidence of synergy. Nevertheless, as Bevacizumab is a standard of care in the frontline treatment of patients with ovarian cancer, the addition of Olaparib to that regimen showed again that Olaparib had benefit whilst all the patients were taking Bevacizumab. The PRIMA study with Niraparib did not have any Bevacizumab at all in it, and could be criticized, I suppose, because of that. However, there are many countries within Europe where Bevacizumab is not routinely used, and this trial also showed a significant benefit in the HRD positive population and less of a benefit in those patients who are HRD negative. Finally, the VELIA trial with Veliparib, which is a drug that's not been trialed greatly within Europe, was designed again in a slightly different way, because the drug was given with chemotherapy and then as maintenance. Unfortunately, this trial did not have a maintenance alone arm, so it's not possible to disentangle the effect with chemotherapy from post-chemotherapy. But again, it showed on an intention to treat population a significant improvement in progression-free survival, and those subgroups again of BRCA mutated, HRD positive and HRD negative all showed an effect, but that effect diminished as the tumours became more proficient in the repair of DNA damage. I think our use of PARP inhibitors in the treatment of ovarian cancer is now going to change as a result of the 3 first-line trials. Up until now, we've been using PARP inhibitors in patients with recurrent ovarian cancer who've responded to platinum-based chemotherapy. Last year, we saw the SOLAR-1 data taking Olaparib into the first-line setting, maintenance therapy in the BRCA mutated population. And we now have 3 trials that show that the effect of PARP inhibitors can extend into non-BRCA mutated ovarian cancer. So I believe now that we're going to see a much greater use of PARP inhibitors in the first-line setting, which will of course have implications for its use in recurrent ovarian cancer.